Hello, I'm Cynthia. This is Module 4 discussion on depression in children and adolescents. Children may display symptoms of depression that are not typically displayed in adults with depression. Children may complain of feeling sick, having a headache, or stomach ache. They may refuse to go to school or have poor performance in school. Children may start to have nightmares. They may have unfounded fears, such as their parent or caregiver dying or leaving them. Children may have a change in eating or sleeping patterns. They may become angry, irritable, or show hostility towards others. Children may have trouble with relationships with family members or other children. Older children may seem to sulk. They may talk or make attempts to run away from home. They may have thoughts or expressions of suicide or self-destruction. Teens may have some of the same symptoms that adults do with depression, but it seems like they have more severe withdrawal in their depression. Some of these symptoms are similar to what non-depressed children will have in their lives, except that non-depressed children usually these symptoms are transient. They will get over them within a couple of weeks. Parents should be concerned if these symptoms persist for like more than 2 months and don't respond to reasonable parental interventions and seem to pervade the child's life. They're consumed with these thoughts or behaviors, and it doesn't just remain confined to one aspect of their lives. Some adults can trace their sadness and their self-dislike and discouraged feelings back to childhood or adolescence. The pathophysiological mechanisms for depression have revealed links between depression that runs in families and changes in brain structure and function. Some that sometimes precedes the onset of depression. This research may help identify biomarkers and early indicators that may lead to better treatment for and prevention of depression. Advanced brain imaging techniques are helping scientists identify specific brain circuits that are involved in depression and yielding new ways to study the effectiveness of treatments. Biologically, depression is associated with a reduced level of neurotransmitter serotonin. A decreased size in some areas of the brain and increased activity in some areas of the brain. Neurotransmitters that are possibly involved in depression consist of dopamine, norepinephrine, and epinephrine, which is also called adrenaline. Corticotrophin releasing factor, or CRF, a stress hormone and a neurotransmitter may be involved in depression and anxiety disorders. The degree to which these chemical messengers are disturbed may be affected by other factors such as genetic susceptibility. For example, researchers have identified an effect in the gene known as SERT, which regulates serotonin and has been linked to depression. There is thought to be a genetic contribution to the development of depression because Children and adolescents of depressed parents are up to 4 times more likely to develop the illness themselves. Teenagers who suffer from conduct disorders such as attention deficit hyperactivity disorder, clinical anxiety, or who may have cognitive or learning problems, as well as trouble relating to others, are at a higher risk of also developing depression. Depression can be a reaction to an environmental stress, including trauma, physical, verbal, or sexual abuse, the death of a loved one, school problems, or being a victim of bullying. Peer pressure and is an indicator of a risk for childhood depression. Gay teens are at a higher risk for depression, thought to be because of the bullying by their peers and potential rejection by family members. Teens in the military families have been found to be at risk for experiencing depression as well. Depression can exacerbate the severity of other health conditions such as asthma or obesity. Depressive episodes often persist, reoccur, or continue into adulthood. One of the most common used medications to help relieve symptoms of depression in children are selective serotonin reuptake inhibitors, the SSRIs. Serotonin is one of many brain chemicals that transmit messages between brain cells. The body produces serotonin by converting amino acid tryptophan. Serotonin has been called the feel-good chemical because it induces a relaxed state of well-being. SSRIs inhibit the absorption of serotonin into the bloodstream, which keeps a higher level of serotonin circulating in the brain. Because depression is associated with low levels of certain brain chemicals, including serotonin, dopamine, and norepinephrine, SSRIs can relieve depression by increasing the amount of available serotonin in the brain. SSRIs doesn't cause the body to make more serotonin. They simply help the body use what it has more effectively. Some of those medications are Prozac, Zoloft, Paxil, Effexor, Pristiq, Celexa, Lexapro. Sometimes tricyclic antidepressants are used in children and adolescents, not as common as the SSRIs. TCAs work by preventing the reabsorption of noradrenaline and serotonin back into the nerve cells. This prolongs the mood lightening effect and of any released noradrenaline and serotonin, and this way it helps with the depression. Medications that are not used as much anymore is the monoamine oxidase inhibitors. These medications reduce the amount of monoamine oxidase, a substance that breaks down the neurotransmitters. This helps make the symptoms of depression better. Although antidepressants are generally safe for children and adolescents, the U.S. Food and Drug Administration has placed a black box warning on all antidepressant medications, and the warning says that there is an increased risk for suicidal thinking or attempts in youth taking antidepressants. Youth and young adults should be closely monitored, especially during the initial weeks of treatment. Since children and teens are less certain to respond positively to medications for depression than adults, it is especially important to use a child psychiatrist who specializes in psychopharmacology to consult with the children's medication needs. And this is the end of my discussion.